Okay, I think so. We are live. Hello, friends. Good evening. So there has been some delay due to some technical issues. But still, yes, we are back. So today we would be discussing the most important 30 questions from Obs and Gyne. I have divided in such a way that each of these questions are from different topics, so that we can briefly touch upon all these 30 topics. Okay. So yes, good evening, everyone. So we had talked, yes, good evening, Abdul, God Slayer, KK, Muhammad, Vishal, Ashish, Nandini, Priyaranjan, good evening to all. So before we start, how's your preparation going on? How's it? What are the difficulties you're facing? Too much stress or the new change in the NEET exam that happened recently? Hello, Moulika. Good evening, Arundhati, Ankit. Good evening to all. Good evening, Moulika. Okay. Yes, doing well. Yes, very good to hear that. Vanakkam, Sundar. Yeah, Sundar has told Vanakkam. Okay, Vanakkam, Sundar. Yeah, it's good to know that it's going well. Like I'm receiving few messages from other students as well, saying that mainly this NEET PG has been postponed. Will this happen to FMGE? What will happen? So as of now, that's not in our hands, right? So don't be in that assumption that NEET PG has been cancelled, something can happen to the FMGE exam. Absolutely no. There are few variables in this exam which is not under your control. What is under your control as of now? Keep on revising. Make the most of each of the minutes. Okay, don't waste any time. Don't fall into all those questions, those anxieties, confusion. Will it happen? Will it not? Nothing like that. You focus on your studies. This is a very crucial time, and you don't want to spend any unnecessary amount of time on all those confusion. You are going to study thoroughly during this time. Utilize each and every minute. Okay, that's very important, dear friends. And again, NB has that thing to surprise everyone, that this time the surprise would be that the exam is on time only. Okay, so don't be under any assumption that there is some change or anything. You're going to just think that yes, I have that exam on that day and I'm going to do wonderfully well, and you are going to utilize each and every minute that is there in these remaining days. Okay. हाँ, डर है कि एफएमजी भी पोस्टपोन हो जाए। डर तो सबको होता है, पर अभी ये जो वेरिएबल्स है वो आपके हाथ में नहीं है ना। जो भी आप अभी कर सकते हो, यानी कि जबरदस्त पढ़ाई करो। ओके, only thing that's now there in your hand is your studies, your preparation. Okay, don't be under assumption they are going to change or anything. Okay, yes, Mohammed, you are going to give it your full strength. Exactly. Yeah, let's go. So let's start the Super 30, right, from Obs and Gyne. Let's start the questions first, one by one. So first question, which of the following is the least likely physiological change in pregnancy? Increase cardiac output, increase in intravascular volume, increase in stroke volume, increase in peripheral vascular resistance. So what happens normally in the physiological changes during pregnancy? So as you know, during pregnancy, the cardiac output increases. So cardiac output is again influenced by your stroke volume as well as heart rate. In pregnancy, heart rate increases, stroke volume increases. Again, the intravascular volume, which is there, increases. The total blood volume increases, the plasma volume increases, the intravascular volume increases. But what happens to the peripheral vascular resistance? The peripheral vascular resistance decreases. Both your diastolic blood pressure and systolic blood pressure also decreases. Why does this happen? This is because of vasodilatation. There is vasodilation that happens under influence of progesterone, again due to which your peripheral vascular resistance decreases, systolic blood pressure decreases, diastolic blood pressure decreases. So let's see all the important other physiological changes that you should know. As we were discussing, the blood volume increases, the plasma volume increases. So what will happen? So much volume. So pregnancy is like a pani state. So much volume is there. So what will happen? The net effect is hemodilution. there is a net hemodilution that happens. Due to this dilution that happens, the patient has lower levels of hemoglobin. That is why these women have physiological anemia. They have lower levels of platelets. That is why these patients have gestational thrombocytopenia. So if they just ask you what happens to hemoglobin, hemoglobin decreases. Platelets decreases. This decrease in hemoglobin is known as your physiological anemia. Decrease in platelets is known as gestational thrombocytopenia. So one like a small error that students have as a misconception is, so hemoglobin decreases, that everyone knows. What about RBC mass? So please understand that RBC mass actually increases, but it is due to this hemodilution that the hemoglobin per deciliter, that's a gram per deciliter that we write, that is hemoglobin levels actually decreases. So RBC mass increases, hemoglobin levels decreases. So again, there is a lot of iron required during pregnancy for the increase in blood volume for the fetus. So the iron requirement increases. These women are at increased risk of having thrombotic complications. So anything that is related to thrombus increases, such as your clotting factors increases, fibrinogen increases. A very important point. The clotting factors that actually decreases during pregnancy, just two, those decreases are factor 11 and factor 13. They actually decrease during pregnancy. What about proteins? The proteins increases. So proteins means including your globulins. Proteins increases, globulins increases. So again, there is an exception. All proteins increases except albumin. So albumin level actually decreases. So usually you have albumin levels more than globulin in pre-pregnancy state. So in pregnancy, the albumin decreases, globulin increases, due to which the albumin to globulin ratio, that is the AG ratio, becomes 1:1. So these are the other hematological changes that you should know from this. Okay, so very important. They often test about the physiological changes that happens during pregnancy. Is it clear? Yes? Okay. So moving to the next question. Nuchal translucency in USG can be detected at dash weeks of gestation. Options 11 to 13, 18 to 20, 8 to 10, 20 to 22. So as you know, we have a special scan at 11 to 13 plus 6 weeks known as NT-NB scan. It's a part of aneuploidy screening. What is aneuploidy? Where we try to detect some chromosomal problems in the baby. So we have NT-NB scan, which is ideally done between 11 to 13 plus 6 weeks. 13 plus 6 means 13 weeks and 6 days maximum. So we do it between 11 to 13 plus 6 weeks. Very, very important. So usually for aneuploidy screening, we do screening in the first trimester. Apart from NT-NB scan, the next parameter that we check is double marker. The next thing is double marker. Again, double marker is also tested between 11 to 13 plus 6 weeks. And the markers that are tested include beta-HCG and PAP-A. Beta-HCG and PAP-A, repeatedly tested in previous questions as well. In the second trimester, what all do? You do triple marker. Either you can go for triple marker or quadruple marker. Triple or quadruple marker. Triple marker includes your ABC, that is alpha-fetoprotein, AFP, beta-HCG, and unconjugated estriol. Unconjugated estriol. In quadruple marker, apart from these three, the fourth one is inhibin. Please note the inhibin that is measured is inhibin A. So let's have a look at this nuchal translucency in ultrasound. So this is basically the translucent area that is there behind the nape of the neck. The other points that I want you to take from this. The first point is it is done between 11 to 13 plus 6 weeks. If they ask you at what crown rump length do you do this? The CRL, that is from the top at the head of the baby till the bottom of the baby, we measure the crown rump length. This crown rump length should be between 45 to 84 millimeter so as to assess this. The magnification that is there, in this magnification, the area that is seen, yes, 45 to 84, yes. And the magnification, the area that is seen include the head as well as the thorax of the baby. Once the option that was given, it was not actually in FMG, previously in need, the option that was given was head, the thorax and abdomen. Again, note that the abdomen is not included. It is only the head and thorax of the baby. We take a mid-sagittal plane for this. We are going to take a mid-sagittal plane and the transducer should be parallel to the direction of nose. You can even skip this point, but the key points here, extra points that I want you to take is 45 to 84 magnification, head and upper thorax, mid-sagittal section is used. Final point. What is the cutoff where you say that NT is abnormal? If you see that the nuchal translucency is more than 3 millimeters, it is more than 3 millimeters, it is taken as abnormal. If you have high or abnormality in the NT-NB scan, they give you that NT-NB scan is abnormal. What are you going to do next? The next thing that you're going to do is you will go for karyotyping, so as to rule out aneuploidies. Karyotyping can be done in various methods. You can do chorionic villus sampling or amniocentesis, depending on the period of gestation. Again, I'm not going to the depth of these. Okay, I hope you already know. If you want me to comment on this, you can again just give me a hint in the comment section as well. So you have chorionic villus sampling, amniocentesis for karyotyping. Okay, so initially, if you see an NT-MD and abnormality, next thing is karyotyping. If you see that even after karyotyping, everything is normal, what is the next thing that you will suspect for this patient? The next thing that you're going to suspect is CVS anomalies. You're going to suspect CVS anomalies are going to be suspected. You're going to do a detailed fetal echo, so as to rule out cardiovascular system anomalies for this patient. Okay, so yes, the correct answer is 11 to 13 plus 6 weeks. Coming to the next question. So you have a 27-year-old female who has presented with 2 months of amenorrhea and she has regular cycles. So she has amenorrhea. Ultrasound shows that there is an adnexal mass of 3 into 2.5 centimeter. The HCG is only 2,800. There is no fetal pole, no cardiac activity. What is the next step in management of this patient? So what are we dealing with? Adnexal mass, amenorrhea, HCG positive. This is basically a case of ectopic pregnancy. So this is a case of ectopic pregnancy. So in ectopic pregnancy, you have medical management, you have surgical management. So they have given one surgical option, that is salpingostomy, and the next A, B, C are all about your medical management, that is methotrexate. So first let's decide, is it medical or is it surgical management? You are going to give a medical management if the patient is hemodynamically stable. The patient should be stable. There shouldn't be significant pain. Significant pain means about to rupture. It should be an unruptured ectopic. It should be an unruptured ectopic. Now, 3 things I want you to by heart here. Must know information. The size of this ectopic should be less than 4 centimeters. There should be no fetal cardiac activity, no heartbeat in the baby, and a small ectopic less than 4 centimeter. No fetal cardiac activity, and beta HCG levels should be less than 5,000. If all these are fulfilled, now I'm going to go for this medical management, less than 5,000. I'm going to go for medical management. So does this criteria fit for a medical management? Of course, this fits in a criteria for medical management. She has an adnexal mass of only 3 centimeter, beta HCG is less than 5,000. There is no cardiac activity. So I choose medical management. Now, next information that you have to know is, how are you going to give this medical management? What is the medical management? This is basically methotrexate. You are going to give methotrexate. Is it oral methotrexate? Is it multiple doses or single dose of methotrexate? So methotrexate is given as injections. So you have intramuscular route, you have intravenous route. The preferred route is intramuscular is preferred over intravenous. And we give single dose of methotrexate. The dosing is single dose of methotrexate. We don't give oral methotrexate. We give either as intramuscular or as intravenous, and it is single dose for ectopic pregnancy. And the dose exactly is 50 milligram per meter square, which is equivalent to 1 milligram per kg. Either you can calculate this as 50 milligram per meter square, or you can calculate as 1 milligram per kg. What is this meter square? This is basically the total body surface area of the woman. Total body surface area of the woman. So now let's come back to our options. So first is oral methotrexate, which is out. Next is multiple dose of methotrexate with leucovorin rescue. Have we heard this somewhere else? Yes, I'm getting the answer as well as B in many places. Okay, B, someone has commented B, someone has commented C, D, all the answers. Where have we seen multiple dose of methotrexate, which is given in between with leucovorin? This is actually right, but not for ectopic. This is given for your GTN, gestational trophoblastic neoplasia. Patients with GTN or gestational trophoblastic neoplasia, instead of giving single dose of methotrexate in GTN, we give on alternate day. We give on day 1, day 3, day 5, day 7 methotrexate, which is in between interspersed with your leucovorin. So on day 2, day 4, day 6, day 8, in between I am going to add leucovorin, which is your folinic acid. So this is basically your regimen for GTN, folinic acid and methotrexate. So what is the correct answer here? Single dose of methotrexate injections. Hope that's clear. Yes. Is the speed all right? Should I decrease the speed or anything, or increase the speed? Okay. Yes. Okay. So moving to the next question. Very important topic, medical termination of pregnancy. I could not form this 30 questions without adding one question on this MTP, medical termination of pregnancy. So a female presents at 21 weeks of pregnancy with features of meningomyelocele for termination of pregnancy. Consent of whom and how many doctors are required? As you know, it's only the patient's consent which is required. And how many doctors beyond 20 weeks? You require consent of 2 doctors. Very good. Everyone is commenting B, B, B. Excellent. This MTP should be very thorough for you. I know it is thorough for you. Just recapping. So we require 1 doctor till 20 weeks. Beyond 20, from 20 to 24, you require 2 doctors or 2 registered medical practitioners. The termination upper limit is 24 weeks, and we can go even beyond 24 weeks if there is substantial fetal anomaly. If there is substantial fetal anomaly, you can even go beyond 24 weeks after approval from your medical board. Medical board. Again, this medical board is constituted by your gynecologist, radiologist, pediatrician, and a member from state. So the doctors that constitute this include your gynecologist, pediatrician, and radiologist. The consent is only required from the patient herself, the mother, the patient, only from the patient, that is the woman, not the husband's consent, not the mother-in-law's consent or anything. It's her body, her wish. So it's the only woman's consent that is required, and records have to be maintained. Always after an MTP, the records have to be maintained. It's very important. If not, it is a punishable offense. In OBS, this is the only easy one. I'm glad that this is an easy one for you because this is a very important topic. Always 2 or 3 questions come from this topic. So I'm glad, Sundar, that this question is easy. This is the only easy. I am sure there will be many questions which is easy for you, but I'm sure this will be one among them. And it's good that this is an easy topic. Yes. So again, just one point. What about medically ill patient? Whose consent will you take if she's medically ill, mentally challenged patient? The guardian's consent has to be taken. Whose consent is taken? Only the guardian's consent would be taken if she's mentally ill or mentally challenged. Yes, excellent, Piyush. Guardian's consent. Yes, coming to the next question. And again, after this Anemia Mukh Bharat program has happened, they are so fond of this question, right? About anemia, how to manage, what are you going to do? So let's see. Under Anemia Mukh Bharat program, mild to moderate anemia is treated using. Yes, I want your answers in this. Iron folic acid, 3 tablets, 2 tablets plus IV sucrose for non-compliance with oral tablets, 𝗵𝗵𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 Yes. Okay, A2AA. Good, good. All of you are attempting it. We'll come to the answer soon. A, B, 3AA. Yes. Okay, okay. Now let's discuss, right? So first of all, you should know with the beginning what is mild, moderate anemia, right? Again, so anemia has been divided as mild, moderate, severe. So I usually teach this with a timeline, right? So usually in pre-pregnancy state, the HB that we expect is 12. It is 12. But in anemia, as I told you, there is so much water, pani, so much plasma volume is increasing. There is hemodilution. So the hemoglobin level is 11. So 11 to this 11.9, this range, 11 to 11.9 is taken as physiological anemia. Less than 11 is the anemia in pregnancy, that is pathological anemia. Again, this has been again divided as mild, moderate, and severe. Mild, moderate, and severe. So what are the cutoffs again? So till 10, that is 10 to 10.9 is taken as mild. 7 to 9.9. Okay, 10 means just less than 10 because 10 is already taken up here. 7 to 9.9 is taken as moderate and less than 7 is taken as severe. So you can remember as SASA, severe less than 7. Severe is less than 7, right? So they are asking you basically management of this part. They're basically asking you management of mild to moderate anemia. What are you going to do in this patient? So let me teach you the algorithm for management of anemia. So any question that you have on anemia, just have a look at two things. What is the hemoglobin level? If at all they have given you period of gestation, what is the period of gestation? Okay, so if a patient has mild to moderate anemia, again, see what is the exact period of gestation. You have just 3 options with you. Okay, you have only 3 options. The 3 options are give her oral iron. Okay, give her some tablets to increase the iron. Give her IV iron, which is also known as parenteral iron, IV iron or parenteral iron. The third option is your blood transfusion. Okay, so first you divided it as mild to moderate anemia for a patient who is less than 34 weeks. Start with the initial small management, that is oral iron. Oral iron. More than 34 weeks, now you have less time. You have to intervene fast. Go with a more rigorous approach, right? So you are going to be more vigorous in the management. You are going to start directly IV iron. If the patient has severe anemia, HB is 5 to 6.9 or less than 5. So again, severe is actually less than 7. We again divide it as less than 5, 5 to 6.9. Less than 5 means very severe, right? It's less than 5. You are going to directly jump to the last measure, that is blood transfusion. If it is between 5 to 6.9, again you divide it as less than 34 weeks, more than 34 weeks. Okay, if she is less than 34 weeks, go with IV iron. More than 34 weeks, you go with blood transfusion. Blood transfusion. Okay, yes. So suppose a patient is taking oral iron. She is taking oral iron and she is non-compliant. She's non-compliant. She's not taking those tablets properly. Her hemoglobin levels are not increasing. That is, she's non-compliant or there is inadequate response. Non-compliant and she has inadequate response. That is, her hemoglobin is not increasing. What will you do for the patient? You will shift to IV iron. IV iron. So as you see here, in mild to moderate anemia, you have two options: oral iron, then shift to IV iron. If she is more than 34 weeks, directly IV iron. So can I choose oral iron among this? What is the problem in the option? So most of the students have gone for 1 and 2, right? So let's see what are the problems in this. IV oral iron, that is iron and folic 3 tablets. How much tablets do you give? We give 2 tablets. So what is the treatment dose that you give? It is 2 tablets. It is 2 tablets. What is the prevention dose that we give for all patients? It is 1 tablet. This tablet that we give in pregnancy is known as a red pill. We give 1 pill for prevention and 2 pills for treatment. That is 2 tablets. How many tablets are given here? 3 tablets. So again wrong. I ruled out option A. Coming to the next option, iron folic acid 2 tablets, which is right, and IV iron. You don't want to overdose the patient with all this, right? You are giving oral iron, IV iron. Don't stress her this much. You don't want to overload her as well. You give either of this. Did I teach you both together somewhere? I told if this is not working, then I will switch over to this one. Or I will give IV iron. You don't give oral as well as IV iron. Again, I am ruling out option number 2 because they have both this oral iron as well as IV iron. Okay, so what is left? The third one, IV sucrose, which is IV iron sucrose. Ideally, should be IV iron sucrose for non-compliance with oral tablets. So there is an iron missing there. IV iron sucrose, if there is non-compliance with oral tablets, is the correct answer among this. Again, the last one, FCM, which is a type of preparation, ferric carboxy maltose, is a type of iron which is usually given as IV. FCM is given as IV, they have given IM. Okay, is it clear? So this is one question, I think, which helps to clear all those concepts. So here you get the dosing of iron, you understand you don't give them both together, you understand you are going to give IV iron if there is non-compliance with oral tablets, right? So I wanted to add this question. Question twist, exactly, Sundar. Yes, I'm glad now it is clear. So, yes, ma'am. Yes, we'll come to it. Okay, we'll discuss those one by one. Yes. Twisted options, exactly, yes. So this twisted options are actually good. It helps you to understand the answer in a much better way, right? So this table is also important. And one question which I see always students making mistake is, let me just ask you, what is the treatment dose of anemia that is given in Anemia Mukh Bharat program? Usually when I ask this, 50% of the students say that elemental iron, 60 milligram folic acid, 500 microgram once daily. So read the question very properly. If they ask you what is the treatment dose of anemia, what is it? 2 tablets. Treatment dose is 2 tablets twice daily. What is 1 tablet? 1 tablet, which is known as your red pill, basically has 60 milligrams of elemental iron, 60 milligrams of elemental iron, and 500 micrograms of folic acid. This is as per your Anemia Mukh Bharat program. 60 milligram elemental iron and 500 microgram of folic acid. You are going to give 1 tablet for prevention. Question asks you what is the treatment dose of this red pill in anemia. The treatment dose as per Anemia Mukh Bharat program is 2 pills. That is 16 to 2 and 500 microgram of folic acid into 2. Okay, is it clear? Yes. The total duration in which you are going to give, Monica, you are absolutely right. The total duration is 180 days during the total of 180 days. Again, in this 180 days itself, you are going to give 180 days in the antenatal period, 180 days in the postpartum period as well. We usually start from the beginning of your second trimester itself. 180 days means nearly 6 months. So you are going to give in the total of the second trimester, third trimester, and also in the 6 months after delivery. Okay, 180 days antenatal, 180 days postpartum as well. Yes, beginning of second trimester. Just the beginning of second trimester itself, we are going to start this. All right. So I hope that's clear. Moving on to the next question. Overt gestational diabetes is defined as blood sugar more than. So first, before going to this overt gestational diabetes, first let's see the simple cutoff of GDM. So in the meantime, you can give the answer for this question as well, waiting for your answers. So in GDM, usually we have two types of tests. You have the 𝗲𝗔𝗃 test and the test that is 75 gram OGTT. 75 gram OGTT, which is given by IADPSG, International Association of Diabetes in Pregnancy Study Group. Okay, IADPSG. So, International Association of Diabetes in Pregnancy Study Group, IADPSG. So in this, we give 75 gram of glucose for a patient who is fasting. Then again, check her blood sugar after 1 hour and 2 hours. The cutoffs that we expect here is the fasting is 92 milligram per deciliter. 1 hour cutoff is 180 and 2 hour cutoff is 153. If you have any one value as abnormal, you will call her as GDM. Any one abnormal, you will call it as GDM. The other one is 𝗲𝗃 guidelines. Okay, the 𝗲𝗃 guidelines, which is given by Government of India. In this, we give 75 again the dose is same. You give 75 gram glucose, but the differences are you give this irrespective of fasting status. Okay, whatever she has taken, if she has taken a meal, tea, whatever, you give it irrespective of her fasting state and you check after 2 hours. If the 2 hours levels are more than 140, so here 140 is the cutoff, you call her as GDM. This is just your GDM. What about overt gestational diabetes? Overt basically means her blood sugars are too high. They are similar to a pre-pregnant patient's blood sugar levels. So overt, the levels are higher than these cutoffs. So let's see what are those levels. So in overt, you will see that FBS is more than 126 milligram per deciliter. The random blood sugar or postprandial is more than 200. When you do this 𝗲𝗃, 75 gram 𝗲𝗃 test, it is again more than 200. HbA1c is more than 6.5. Is this clear? These cutoffs, these are your overt diabetes. This category is known as overt. So again, coming to this answer. So overt, here the answer is more than 200 milligram per deciliter. Okay. Moving to the next question. Transvaginal ultrasound findings in a multiparous female reveal low-lying placenta. What does this mean? So this is the newer classification of placenta previa. Previously, you have the older Brownies classification, which again divided the placenta as 4 types. But let's see this newer classification. Newer classification does not have 4 types. There are just 2, either normal placenta. The abnormalities are either low-lying or placenta previa. Low-lying means ideally the placenta should be at least 2 centimeters away from the level of your cervix, that is this part, which is your internal os. It should be at least 2 centimeters away from the level of internal os. If it is within 2 centimeters, it is known as low-lying placenta. If it is completely covering the cervix or internal os, it is known as placenta previa. This is the newer classification which you have to know. So again, for completion, I have provided the older classification here as well, which is given by the Brownies. This is the Brownies classification, where again the placenta has been divided as grade 1, grade 2, 3, and 4. Grade 1 means placenta is reaching the lower uterine segment. Grade 2 means it is touching the level of internal os. Just remember, T, like 2T, touching is 2. Touching the internal os or reaching the internal os is 2. Touching, you just remember T and T. Grade 3 means it is covering the internal os, but partially covering. Completely covering the internal os is grade 4. You should know this as well, as this was asked previously for Jan 23. Okay, so then latest one is this one, and as per this, the correct answer is within 2 centimeter from the level of internal os. Again, in this topic also, it is very important that you should know how to differentiate between various types of antepartum hemorrhage. So antepartum hemorrhage, most common cause, it is due to abruptio placentae. The next most common is placenta previa. Apart from this, it could be due to vasa previa or placental problems such as circumvallate placenta. Okay, so again, I have discussed in detail this brief, how to quick revision on dividing this abruption, placenta previa, how you can differentiate them, how you can manage them in the remarkable rapid revision and the rapid revision videos as well. Okay, I'm not going into all those details, but at the end, if you want, I can even go through that briefly. Okay, so it's very important. You should be able to differentiate between this placenta previa and abruptio placentae. So if they ask you just few more points about placenta previa, very important points. If they ask you what is the investigation of choice for placenta previa, what is your answer? The investigation of choice for placenta previa is ultrasound. Which ultrasound? TVS, transvaginal sonography, is the investigation of choice. If you can do TVS, can you do a PV? No, PV is contraindicated. PV is going to cause torrential bleeding. You will not do PV for this patient. How will you deliver this patient? Placenta previa commonly tested. Either they will ask you something about induction of labor, or they will ask you about vaginal delivery. Understand that complete placenta previa, you cannot do a vaginal delivery. You will not do a vaginal delivery. The mode of delivery is going to be cesarean section. Repeatedly tested point, tested concept. Understand that placenta is here. The baby cannot burr or make a hole through the placenta and come outside, right? If the placenta, there is complete placenta previa, your answer is cesarean section. C-section is the answer. There is a conservative management for placenta previa, which is known as McAfee and Johnson's regimen. So a patient presents at 11 weeks with mild spotting PV. Coming to the next question. Yes, with spotting PV, ultrasound shows that there is only a gestational sac without a fetal node or a fetal pore. The uterine size is normal. It's actually normal to, it's not a pregnant or 11-week size. The uterine size is normal actually. So what is the diagnosis here? Yes, absolutely. Like all of you are correct. This is basically a case of missed abortion. So missed abortion is a scenario where there has been death of the fetus within the uterus, but there has been no signs of expulsion till now. So this is basically a case of missed abortion. How will you diagnose missed abortion? If I do a scan, if I see that there is a gestational sac, which is more than 25 millimeter, but there is no fetal pole or fetal node, or there is a fetal pole which is more than or equal to 7 millimeter with no heartbeat, which is known as fetal cardiac activity, FCA. So more than or equal to 7 millimeter fetal pole, but there is no heartbeat or cardiac activity. In all this situation, I will diagnose it as missed abortion. This is known as missed abortion. Excellent. Yes. So as we are just dealing about threatened abortion, inevitable, incomplete abortion, this is briefly about all this. So in threatened abortion, patient basically has some amount of vaginal bleeding, but rest everything is normal. You will see that the os is closed, that is the cervical os is closed. There is no passage of fetus or products. Only problem is there is some bleeding, but os is closed, no passage of fetus. Inevitable also, there is bleeding, there is no passage of fetus, but here os is open. Os is open and staring at you. So any time the abortion can happen. It is inevitable. You can't stop it. It is inevitable. The os is open here. In incomplete abortion, as the name suggests, there is nothing to by heart. It's right there in the name. It's incomplete means already some products has been passed. So due to this, there is still more to pass. So the os is open. Complete, again, there is passage of clots. Everything has been completely passed. So the os will be closed. So incomplete os is closed in this scenario. Yes, exactly, Shubham. Threatened abortion, there is actually a threat to the pregnancy itself. There is that threat in the form of bleeding, but apart from that, rest everything is normal. Os is closed, the size of the uterus is corresponding to period of gestation. Yes. Okay. So moving to the next question, which of the following is the smallest diameter of the pelvis? Okay, can you again comment on this answer? Which of the following is the smallest diameter of the pelvis? Yes, is it obstetric conjugate, diagonal conjugate, interspinous, or intertuberous diameter? Yes, the smallest diameter is actually the interspinous diameter. So this is at the level of cavity that you have a small spine, which is your ischial spine. So you have this ischial spine which is projecting. Okay, so this distance between this, that is the interspinous diameter, is the shortest diameter that is there in the pelvis. So this is basically a transverse diameter. The shortest diameter is actually a transverse diameter, which is interspinous diameter, which is nearly equal to 10 to 10.5 centimeters. 10 to 10.5 centimeters. So this spine, this is the place where this diameter is shortest. This is the place where arrest of the baby can happen. This is known as deep transverse arrest. So this is the place where deep transverse arrest can happen. Again, ischial spine has few other importance. Ischial spine is the place where after descending, the baby undergoes rotation. So as you know, there is descent with increasing flexion, then there is internal rotation. So this is the place where internal rotation of the baby happens. So deep transverse arrest at the level of ischial spine, internal rotation at the level of ischial spine, shortest diameter of the pelvis, again interspinous diameter. So if I measure this interspinous diameter, so basically I can insert my fingers and see what is the distance between these two spines. I will feel the spine on this side, on the other side. What is the distance, the interspinous distance? If interspinous distance is less than 8 centimeter, it is suggestive of a contracted pelvis. Interspinous distance less than 10 centimeter means 8 centimeter means it is contracted pelvis. The normal interspinous distance is 10 to 10.5, less than 8 means contracted pelvis. If a question has contracted pelvis, what will you do? You are going to again deliver by cesarean section. What about these obstetric diagonal conjugate? Again, very important diameters. These obstetric and diagonal conjugate, these are seen at the level of inlet, at the inlet of the pelvis itself. So if I just look from lateral, so here you have pubic symphysis, here you have the sacral promontory, and you have the, vertebrae. Here you have the sacral promontory. So you have three types of anteroposterior conjugate. This is anterior, sacrum is posterior. Anteroposteriorly at the level of inlet, you have three diameters. These are the three diameters. So what are these diameters? You have the uppermost diameter, which is known as true conjugate, which is your true, also known as anatomical conjugate. So what is it? It is from the uppermost point of your pubic symphysis to your sacral promontory. Just remember T for T. Topmost one is true conjugate. The next one, which is from the midpoint or the most projecting point of your pubic symphysis, from the midpoint of your pubic symphysis to sacral promontory, this is your obstetric conjugate. Very important, obstetric conjugate. The last one, which is there, which is from the lower border of pubic symphysis to sacral promontory, that is your diagonal conjugate. That is your diagonal conjugate. Okay. Yes, diagonal conjugate. Okay. Yes. So I think all of you know this already. So I'm just finishing up. Okay. I'll just keep it brief. Okay. Yes. So few more questions which come from this. So I want to cover the maximum things which come along with this so that you get the maximum out of it rather than just going on discussing the question answer in 30 minutes. So I thought I'll just add in few points so whoever is attending gets maximum benefit out of it. Okay. So if they ask you which among the following is clinically measured, again, answer is obstetric, the clinically measured one is the lowermost one, which is your diagonal conjugate. If they ask you which is the shortest one among this, shortest is obstetric conjugate. Shortest is obstetric. Among the anteroposterior, I'm saying overall shortest is interspinous. If they ask you shortest anteroposterior, then answer is obstetric conjugate. Is it clear? So just saying diagonal conjugate, what is the total distance that is there? Diagonal is nearly 12 centimeter. Obstetric is nearly 10 centimeters. Anatomical or true conjugate is nearly 11 centimeters. Yes. Okay, so moving on to the next question. Which of the following statement is true regarding complete hydatidiform mole? Complete mole has focal proliferation of trophoblast, has more malignant potential than partial mole. Fetal parts can be seen. P53 marker is positive. Yes, Shubham. So Shubham has commented that intertuberous we measure by knuckle. Yes, that is true. Intertuberous, we usually keep our knuckles like this, and this is the we keep on either side, so you can feel the tuberosities on either sides. Okay, it's good that you know. Okay, which of the following is true regarding complete mole? So let's briefly see what are the changes. The correct answer is it has more malignant potential than partial mole. So here I have given you the complete box which you should know about these two, partial and complete mole. Again, this is from Williams. So the complete mole, basically it is diploid 46XX, partial mole is triploid. The key points about complete mole, understand that complete mole has everything zyada. Okay, everything is more in this. Okay, there is more proliferation of villi. There is marked proliferation of villi. Increased chance of malignancy is more in it. So villus edema is more, trophoblastic atypia is more, everything is more. As all these things are more, again, beta HCG is much more in this. Medical complications are more in complete mole as compared to partial mole. Partial is rare. Uncommon means slightly, the incidence is slightly more than your rare complication. So where is more complications seen? More complications are associated with your complete mole. Again, the risk of malignancy or GTN is again more with your complete mole. The uterine size is again more or large for days with complete mole. So remember, everything is more in case of your complete mole. One difference, P and P. Remember, P and P. Partial has P57 positive. P and P, partial has P57 positive. Next P is, you remember, partial is PANS. Partial, the risk of malignancy is 15%. Complete mole is much more than that. It is 15 to 20%. So I wanted to remember, this complete mole has everything more. Okay. So one exception, P57 is actually positive with partial mole. The second thing is, where do you see embryo? Where do you see fetus? That is associated with your partial mole. Okay, I'm sure you might be knowing this table, but these are the key points that you should know from this. Okay. Coming to the next question, arrange the cardinal movements of labor, its sequence, engagement, restitution, external rotation, and crowning. So the key movements that takes place include engagement. So the first thing is engagement. Next comes descent. This descent is associated with the flexion of the baby. So initially you see that the baby engages, and the engaging diameter, the most common engagement, the most common position in which this engagement happens is LOA or LOT. LOA or LOT. It is actually LOT, left occipital transverse followed by left occipital anterior. The most common malposition is ROP, right occipital posterior. Malposition is right occipital posterior. The engagement is said to occur when the biparietal diameter, when the baby's biparietal diameter passes through the pelvic brim. The biparietal diameter passes through pelvic brim, then the engagement happens. And normally, the engaging diameter in baby, the engaging diameter is suboccipitobregmatic. The engaging diameter is suboccipitobregmatic. So first thing is engagement, then comes your descent with increasing flexion. Next is internal rotation. So again, internal rotation occurs at the level of ischial spine. Next, there is extension. So the baby has internally rotated. Now the baby's head delivers by this extension. So at this time, when the baby is extending, you will see that the baby's head is visible. There is crowning. You can see the baby's scalp or head which is visible. That is crowning. So crowning basically means the fetal head or the scalp is visible, bulging through the vulva, and it does not recede back in between the contraction. So you see the crowning. Next comes restitution. Finally, the external rotation. You can remember this. Either you can remember all these steps or you can remember 𝗵𝗵𝗺. 𝗵𝗵𝗺. Okay, engagement, descent, flexion. Next is flexion, internal rotation, extension, restitution, and finally external rotation. Okay, 𝗵𝗵𝗺, you can use this mnemonic to learn this as well. Okay, so first there is engagement, LOT, engagement, then there is descent with increasing flexion, then the internal rotation, extension, finally baby goes back, that is restitution, and external rotation. These are the various movements that you see. Okay, at least this mnemonic will help you in the last. Okay, 𝗵𝗵𝗺. Okay, so a patient has come to your OPD at 32 weeks pregnancy. She complains of edema. Her BP is 140/90. Dipstick reveals 2+ positive. What is the presumptive diagnosis in this condition? So basically, you have high blood pressure with proteinuria. So this is a clear-cut case of your preeclampsia. Can you label this as chronic hypertension with superimposed preeclampsia? Again, no. So usually the cutoff that is taken is 20 weeks. If you see that there is high blood pressure which is seen beyond your 20 weeks and it returned back to normal. So beyond 20 weeks, you have high blood pressure recording and it returns back to normal within 12 weeks postpartum. This category is taken as your gestational hypertension. This is taken as gestational hypertension. If gestational hypertension is associated with proteinuria or any evidence of end organ damage, you will call it as preeclampsia. Okay, you will call it as preeclampsia. Associated with proteinuria or end organ damage, we are going to call it as preeclampsia. So here I have given all the definitions of gestational hypertension, preeclampsia, chronic hypertension with superimposed preeclampsia. Okay, so one thing I want you to add is here, gestational hypertension, high blood pressure detected after 20 weeks, return back to normal within 12 weeks. If associated with proteinuria or end organ damage, it is known as preeclampsia. Chronic hypertension, high blood pressure recording after 20 weeks, and it doesn't. And the blood pressure does not return back to normal within 12 weeks postpartum. If this is associated with proteinuria or end organ damage, you will call it as chronic hypertension with superimposed preeclampsia. Finally, you have eclampsia, that is a tonic-clonic seizure. Once the question that came was, patient has come to you with high BP, what is the next thing that you are going to do? You are going to assess for proteins. You will simply do a urine dipstick test. Okay, dipstick test. Just adding 2 points with this. So if a patient has hypertension, any of these forms of hypertension, when will you deliver that patient? You will deliver by 37 weeks. You will deliver by 37 weeks. If a patient has severe hypertension, you are going to deliver by 34 weeks itself. Again, vaginal delivery can be done. What is the drug of choice that you will give for hypertension? Drug of choice is labetalol. You are going to give labetalol for this patient. Okay, labetalol is the drug of choice. Coming to the next question, you have a 36-week pregnant female with mitral valve replacement. She is on warfarin. Her INR is 3. What is the next step in management of this scenario? Okay, so patient is basically on warfarin. What are you going to do? So warfarin is a very important drug and that requires constant manipulation and changes during pregnancy. This is known as switch over. We keep on switching between warfarin, heparin, heparin, warfarin. Right. So the thing is, heparin is actually good for the baby. Does not cross placenta, does not affect the baby. Warfarin is good for the mother. It's a very good anticoagulant. So with this timeline, let me briefly teach you how will you manage this warfarin, heparin funda. Okay, so suppose a patient got pregnant. So here she got pregnant, and before that she was on the best anticoagulant, which is basically a warfarin. She was on warfarin. As soon as she gets pregnant, what will I do? I will switch her to heparin. And the heparin that is given is low molecular weight heparin, such as enoxaparin. Sometimes instead of giving this low molecular weight heparin, they just give examples such as enoxaparin. So you should know this as well. Yeah, okay. Next, once she becomes 12 weeks, so now the main embryogenesis period is over. You are going to again shift her back to warfarin. But warfarin has long action. Again, it can go to the baby, anticoagulate the baby. So just before delivery, you are going to always switch over by the time of 36 weeks. At 36 weeks, you are going to shift from warfarin to heparin again. You are going to shift to heparin, and the heparin that is given is low molecular weight heparin. So what will you do at 36 weeks? You are going to stop warfarin and you will switch over to low molecular weight heparin. Okay, is that clear? You are going to switch over. Yes, Bhuvan has asked, aspirin is shown to reduce colonic cancer preeclampsia. Yes, but Bhuvan, we won't be giving it here. Already she is 36 weeks. So there is no point of adding aspirin to prevent preeclampsia at 36 weeks period of gestation, right? So here answer is stop warfarin and shift to heparin is the correct answer. Okay, no point of adding aspirin at this point of time. Now coming to a question on postpartum hemorrhage, a female has presented with PPH with history of heart disease. She's already treated with oxytocin and okay, there's no ergometrin, okay. She's already treated with oxytocin and didn't show any improvement. What is the next drug that can be effective in this patient? Okay, ergometrin should have been in the options actually. So the key thing that you have to understand in this is, so if a patient has PPH, the first thing, the drug of choice is basically your oxytocin. The drug of choice is oxytocin. Next comes ergometrin. So if a patient has hypertension or if the patient has heart disease, this ergometrin is absolutely contraindicated. So question already has hypertension or heart disease. You will not think of ergometrin. You will go to the next option, which includes your carboprost. So that's the answer, the carboprost. Again, carboprost is contraindicated in your asthma. If a patient has bronchial asthma, again, you're going to avoid this carboprost. Next comes misoprostol. And finally, tranexamic acid is added as an adjuvant. So you should know this order. Okay, how you're going to give. Oxytocin, the route in which we give, usually you have IV, that is IV infusion, or you can give as intramuscular injection. Please note that IV bolus is not given. You cannot give IV bolus for this patient. Ergometrin, the preferred dose is intramuscular over IV. Intramuscular is preferred over IV. Initially, we start with a dose of 0.2 milligram and the maximum dose that we give is 5 doses. Okay. Carboprost, the dose in which that you are going to start is 250 microgram. And maximum dose that you give is 8 doses. So one question that was asked is, what is the maximum dose of carboprost that you can give? 250 into 8. That means 2000 microgram, which is equal to 2 milligram. The maximum dose that is given is 2 milligram. Okay, some key points that you should know from this. Yes, Shrivam, exactly. You don't give carboprost in bronchial asthma again due to bronchoconstriction. You will not give ergometrin in hypertension, heart disease. Very important contraindications. Just after delivery, what is the position of the uterus? Just after delivery, you see that the position of the uterus is just below the umbilicus corresponding to 20 weeks. Again, this position is maintained for the next 24 hours. Yes, the position is maintained for the next 24 hours. Then the position of the uterus keeps on decreasing at the rate of 1 finger breadth per day. At the rate of 1 finger breadth per day, that is 1.25 centimeters per day. So just after delivery, 20 weeks, for the next 24 hours, it remains the same. Then it is going to decrease at the rate of 1 finger breadth per day, which is equal to 1.25 centimeters per day. All right. So an RS negative patient who has underwent amniocentesis at 16 weeks, what is the dose of anti-D to be given to this patient? What is the dose of anti-D? Okay, Abhishek has stated all answers. Option is A itself. So Abhishek, you can have a look at this question. I hope here the answer is not A. Right? सब आंसर A ही है. Okay, इसमें तो A नहीं है अभिषेक. अभी आप कमेंट कीजिए. Okay, so here the answer is 300 microgram. Okay, the correct answer is 300 microgram. Anti-D again very important. The dose of anti-D is 300 microgram, which is given as intramuscular injection. So again, if there is any event where there is feto-maternal hemorrhage, there is chance of feto-maternal hemorrhage, which can lead to immunization, you should immediately give anti-D, such as chorionic villus sampling, amniocentesis. She has any bleeding episode, you turn the baby, that is external cephalic version, cesarean section, all these you will give anti-D. What is the dose? 300 microgram intramuscular injection. What about this 50 microgram? Can I give 50 somewhere? Yes. If you have a patient who is less than 12 weeks, who require anti-D, that is an exception where you're going to give 50 microgram. Less than 12 weeks, you're going to give 50 microgram. So again, how will you give anti-D? When all will you give anti-D? Patients come to me who is Rh negative. So first thing I will do is ICT, indirect womb test. Patient, they ask you, patient is Rh negative, what will you do next? ICT. So ICT is negative. Again, I will repeat this ICT 4 weekly. So patient has come in 8 weeks, I repeated 12 weeks, 16, 20, 24, 28. So finally, I reached 28 weeks. So at 28 weeks, we will give 1 dose of prophylactic anti-D. This is known as routine antenatal anti-D prophylaxis. So you will give antenatal dose of anti-D, antenatal anti-D. This is basically your prophylactic anti-D. Now again, the patient has gone and she has delivered. After delivery, you are going to check the blood group of the baby. If you see that the baby blood group is positive, then again in the postpartum period, next you are going to give the next dose of anti-D. Okay, yes. Prophylactic dose, 28 weeks. Again, all these doses are 300 microgram intramuscular. Only if it is less than 12 weeks, it's going to be 50 microgram. Okay, is it clear, Bhuvana? Yes, clear for everyone? Yes. So a pregnant woman has presented with fibroids at 26 weeks pregnancy, and she has acute abdominal pain, low-grade fever, mild leukocytosis. Which of the following is false regarding her condition? Yes. So the first you come to the diagnosis, patient with fibroid pregnancy. Think about red degeneration. Key features, fibroid pregnancy pain, it is red degeneration. What are the key other features that they will give? The patient has fever, the patient can have vomiting, the patient can have leukocytosis, the typical features that happens with red degeneration. Why does red degeneration happen? Red degeneration happen because usually there is small thrombosis to the vessels that supply the fibroid. So there is vascular thrombosis. You see that the leukocytes are increased, the ESR is increased, everything is raised in this condition. Okay, so this patient has so much pain, patient has this fibroid. Will you just take out the fibroid? Never. Patient should not undergo any form of surgery. But how will you manage then? You are just going to give analgesics. You will just give analgesic. You will just provide bed rest for the patient. Analgesic, rest, and IV fluid. It is conservative management is the treatment. You will not do myomectomy. Again, few additional points. When do you see this problem, red degeneration? Again, this question gives you 26 weeks. When is it? It is in 2nd and 3rd trimester. So this is seen in T2 and T3. That means, in other words, I can write in the 2nd half of pregnancy. You see these things in the second half of pregnancy. If you have to choose between T2 and T3, that is second trimester and third trimester, it is most common in the second trimester. Management is expectant management. Again, students, they test this concept. They will give you fibroid in pregnancy in various ways. You have done cesarean section, found a fibroid. You did laparotomy for some other thing, you found a fibroid. Do not touch these fibroids during pregnancy. Myomectomy is not an option that you're going to choose commonly if you have fibroid during pregnancy. They are very vascular. They will bleed profusely. Is it clear? Yes. So again, myomectomy is not the answer that you're going to choose there. Identify the HSG image that is shown below. It's a common question that I get from students as well. Many times there is doubt regarding how, whenever this Mullerian anomalies come, students get scared, right? How to diagnose this? What is this? Bicornuate, septate, didelphys, unicornuate? What is happening? So is this bicornuate uterus or a septate uterus? Yes, again, I'm getting B, that is bicornuate, and C, that is septate uterus. Future obstetrician, yes, glad to see you here. Yes. Okay, C, B, yes, good. So let's see what's the basic difference. Let me tell you the key what happens in both this. Okay, definitely not didelphys, right? In didelphys, what happens? You can see two cervix, you can see two uterine cavities as well. So not didelphys uterus. Okay, there is just one cervix which is leading to two uterine cavities. The first thing that you will see is, are they close together or very much further apart? If you see that they are closer together with an acute angle, if there is an acute angle and this distance, this intercornual distance is less than 4 centimeter, which is suggestive of septate uterus. Okay, so let's see image wise one by one. So first, this is your normal uterus. So you can see the uterine cavity, both the tubes, the spillage can be seen. Again, as spillage can be seen, HSG can be used for even checking tubal patency. It is used even for tubal patency. So whenever you have an HSG image, I want to look right from the cavity, go to the tubes, then look at the spill. In the cavity, I'm just teaching you stepwise. In the cavity, sometimes you see this defects, irregular defects like this. Okay, small, like some rat has eaten over it. Okay, small, irregular defects. These irregular filling defects, irregular filling defect is seen in case of Asherman. Excellent. It is seen in case of Asherman syndrome. Excellent. Sometimes not this rat type of, Chuha type of this filling defect. You see very irregular filling defect. You see it is very irregular filling defects. What is this regular filling defect? Regular filling defects. So irregular was Asherman. You see regular filling defects in conditions such as fibroid, that is submucosal fibroid, or even polyp. So in polyp and fibroid, you see regular filling defect. So in cavity, I taught you two things. Next, you will look at the tube. So if you see that right here, the dye has stopped. That means block here. That is cornual block. So that means cornual block. Cornual block. Next is, you see dye has gone through the tube, but there is no spill. That means there is distal block. What is there distally? Fimbria. That is fimbrial block or a distal block. All right. So coming to other abnormalities. Okay, Mullerian anomalies. So I just taught you how to read a HSG. Yes, now let's go into the anomalies. So here you see two cervix, two uterine cavity, clear-cut case of didelphys uterus. Two cervix, two uterine cavity, didelphys uterus. So in the next image, so it's actually wrongly marked, yes. In this image, you are seeing that the angles, they are very further apart. They are not acute, they are actually obtuse. You see obtuse angle. The angle is obtuse, more than 90 degrees. And you see that the intercornual distance is too much. It is more than 4 centimeter. So if you see something like this, which is further apart, you will think about bicornuate uterus. If you see that they are closer together, the angle seems acute, the intercornual distance is less, then you will choose your septate uterus. Is it clear? This is basically your bicornuate uterus. Mark here, this is bicornuate uterus. So how will you differentiate? Let me draw it here for you. So if you have this intercornual distance, the angle is acute and the intercornual distance is less than 4 centimeter. This is basically your septate uterus. If you see that the intercornual distance is more, it is obtuse. It is more, it is obtuse angle. And intercornual distance is more than 4 centimeters. It is suggestive of bicornuate uterus, right? Yes, obtuse and acute ones. The next one is you see only uterine cavity on one side, other side is not seen. This is your banana sign, seen in unicornuate uterus. Here answer is unicornuate uterus. This is your unicornuate uterus. Here you just see a small dip, which is arcuate uterus, less likely to be asked for you. Yes, banana sign is seen in unicornuate. Yes, someone has commented rightly, then they changed. Okay, yes, this is the correct picture. Septate, you are seeing more acute angle. More further apart, you are seeing bicornuate uterus. Okay, septate, there will be very close by image, bicornuate further apart. Okay, so here it is more acute in the image which was shown, and again the angle is less than 4 centimeter, which is suggestive of a septate uterus. Septate uterus. Okay. Yes. Normal variant. Shubham has commented normal variant. Arcuate is a normal variant. Arcuate is actually the least symptomatic. There is a very small dip. It is least symptomatic rather than saying a normal variant. So just few points from this. Which is the most symptomatic anomaly? S and S. Symptomatic is septate uterus. Which is the most common uterine anomaly which is associated with abortions? Again, septate uterus. Among these anomalies, which is the one which is associated with infertility? Again, septate. Our bicornuate, 𝗙𝗵𝗔, arcuate does not cause infertility. Okay, it is again septate uterus. Okay, final point about septate uterus. How will you manage septate uterus? You are going to resect the septum. How will you resect it? Through the cervix, you will pass a hysteroscope and you will cut out this septum. This is known as hysteroscopic transcervical resection of septum. Hysteroscopic transcervical resection of septum. Shubham has commented metroplasty. No. Please correct that if you have that misconception. Metro means something related to muscle, right? We do metroplasty for bicornuate, where I have to repair the muscle and correct it. For septum, there is just a partition, just like a parda which is there in between. Okay, you just have to cut it from below. That is septoplasty. Metroplasty. So metro means something related to muscle. Metroplasty is for bicornuate uterus. Okay. Yes. No, please don't be sorry. I'm very glad when you make mistakes or anything. I'm glad that you are answering so well. So mistakes are good if you make it before the exam. Okay. Only target is before exam. All this mistake has to be corrected. Okay. So it's good that you make mistake, correct here, and help others to correct their misconceptions. Okay. Please feel free to answer. Okay, make all mistakes now. No mistakes for the exam. Yes, yes. If bicornuate causing preterm labor, you will do a metroplasty. Excellent, correct. Chemotherapeutic agent which is used in carcinoma cervix, very commonly asked question. The chemotherapeutic agent is cisplatin. So carcinoma cervix, very commonly asked. You have two options. You have the option of surgery. The next option is radiotherapy. Again, this radiotherapy that we give is CCRT, which is known as concurrent chemoradiation. CCRT means concurrent chemoradiation. Concurrent chemoradiation. That means I am adding chemotherapy along with radiotherapy. But if you have to choose one between chemo and radio, they're given separately. What will you choose? The main modality is radiotherapy, and this chemotherapy acts as a radiosensitizer. It acts as a radiosensitizer. What is the chemotherapeutic agent that is commonly given? It is cisplatin. So when will you do surgery? When will you do radiotherapy? So I'm going to do a surgery if it is the initial stages, such as stage 1A1, stage 1A2, 1B1, 1B2. Next comes your 1B3. Okay, 1B3 is not included here. And finally, 2A1. Again, this is important. When all will you do surgery? I'm going to do the initial stages A1, A2, B1, B2, and 2A1. 1B3 is actually radiotherapy. And also, if you have 2A2 till 4, your answer is again going to be radiotherapy, that is concurrent chemo radiation. Okay, CA cervix is very important. HPV vaccine is very important. Okay, so many questions from this. Okay, CA cervix, vaccination, HPV. So we will see a question on HPV as well shortly, where I'll teach about HPV. So this is the management that you're going to give for CA cervix. Yes. So in the normal menstrual cycle, the X is marked by which of the hormones? Very direct question actually. It is just to have an overview of the various hormones during menstrual physiology. The hormone which is marked here, which is increased in the second half of your menstrual cycle. So you can see two halves here. The initial half is the follicular phase. The next one is luteal phase. Which phase is fixed? Question. Luteal phase is fixed. Luteal phase is fixed, which is 14 days. Luteal phase is fixed, which is 14 days. So here you have the date of your ovulation. So again, if I have a look at the uterus, initially I will have proliferative phase. Proliferative phase. In the next part, I will see secretory phase. So what are you seeing here? This hormone which is suddenly increased in this luteal phase or secretory phase, this is basically your progesterone. Who produces progesterone? Progesterone is produced by corpus luteum. Progesterone is produced by corpus luteum. Corpus luteum produces what all hormones except from progesterone? One is progesterone, the others include estrogen, and the third is inhibin. And the inhibin that is produced is inhibin A. So these are the hormones that is secreted. Okay, so the second graph, the second thing which you see here is of course the other hormone, which is your estrogen. So the main peak which you see here in the secretory phase is progesterone, and the next one is estrogen. So let's again trace this estrogen which is here, which is seen in red. So you can see that estrogen increases initially here in the initial follicular phase, then again in the secretory phase. The main hormone that you see, which is peaking just before ovulation, this is your LH. Next question, if they ask you which is the hormone responsible for ovulation, answer is LH. Hormone responsible for ovulation, LH. Hormone which is responsible for LH surge, which hormone do you see just behind your LH? Just like we push you for the exam, like motivate you, just like that, there is someone standing just behind your LH, motivating him to rise and peak. Who is that? It is your estrogen. So, or estradiol. Estradiol is the type of estrogen which is main in reproductive age group. Okay, so estradiol is there, who is responsible for the LH surge to happen. How many hours after LH surge does ovulation happen? LH surge to ovulation is nearly 36 hours. LH peak to ovulation is 12 hours. 12 hours. So even just today I received a query in my Insta as well. The question was this one: which of these, LH or FSH, is responsible for final maturation of the follicle? So the hormone which is responsible for this ovulation to happen is LH. The hormone which is responsible for final maturation of follicle is FSH. It is FSH. And FSH, as the name suggests, follicular stimulating hormone or follicle stimulating hormone. It is the one which initially stimulates the follicle. It is the hormone which initiates the growth of follicle. So basically included this slide so that I can discuss all these key points about the various hormones. Okay, they often tend to ask from the basics, from the hormones. That's why, again, this has been previously asked as well. We discuss all these hormonal changes. Okay, so the hormone which is responsible for the initial growth of the follicle is your FSH. Final maturation, again FSH. Hormone responsible for ovulation, LH. Hormone responsible for LH surge, it is estradiol. And the hormone which is predominant in the proliferative phase, progesterone. The other hormones are estrogen as well as your inhibin. Okay, it is an estrogen as well as inhibin. The next hormone which you see, which was initially high, then it decreases, then again slightly peaks just before ovulation. This is your FSH. Yes, okay, yes. Okay. All of the following statements are correct except menstrual blood is mainly arterial. Prostaglandin released at the time of menstruation is FMGE2. Zona basalis regenerates the endometrium during the next cycle. Anovulatory cycles are painless. Okay, so let's see this findings one by one. So why does this menstruation happen? Menstruation happens because there is constriction of one type of artery. What is that artery? Spiral artery. So this is basically, this is a cross section of your endometrium. You are seeing initially the uterine artery gives off radial artery, then basal artery, spiral artery. Again, the layer of endometrium is divided as functionalis layer, which is supplied by spiral artery, and basalis layer, which is supplied by your basal artery. So what happens during menstruation is that there is constriction of these functionalis layer. There is constriction of the spiral artery, not functionalis layer, there is constriction of this spiral artery, due to which the functionalis layer is actually shared. So which layer is shared? Functionalis layer is shared. Which layer regenerates? Basalis layer regenerates. The blood that is coming is basically by the constriction of spiral artery and shedding of this functionalis layer, and it is basically the arterial blood. Why does the spiral artery constrict? It is due to your prostaglandins. Which prostaglandin? The main prostaglandin is PGF2-alpha. It is PGF2-alpha is the main prostaglandin which is responsible. Okay, again, this constriction, all these things are responsible for the pain during menstruation, known as primary dysmenorrhea. So here menstrual blood is mainly arterial, correct. Zona basalis regenerates, correct. And if you don't have an ovulation, you have an anovulatory cycle, it is usually painless. The patient does not have pain. That is why in the initial years, just after menarche, girls don't have much pain. Usually the cycles are anovulatory and there is no pain associated. But later on, due to constriction of these spiral arteries under influence of PGF2-alpha, there is pain in these patients. Okay, so this is basically the prostaglandin that is released, PGF2-alpha. Yes. In polycystic ovarian disease, all the following are seen except there is increased risk of endometrial cancer, increased FSH, insulin resistance, and hirsutism. Which among the following is false among these? Yes. Bhuvana has commented 2, increased FSH, Shubham 2. Yes, excellent, excellent. B. Mollika has 2. Yes, that's absolutely right. So basically, the small follicles keeps on producing estrogen. These patients have high levels of estrogen. This estrogen leads to endometrial hyperplasia, endometrial cancer. Estrogen usually gives a negative feedback due to which FSH level is low in these patients. These patients have higher level of LH, due to which LH to FSH ratio is 3:1 or even 2:1. 2:1 or 3:1. These patients have no ovulation, no corpus luteum, less levels of progesterone. Progesterone is low. They have high levels of insulin resistance. Again, due to stimulation of this LH, there is fecal hyperplasia. Fecal hyperplasia, due to which the patient can have androgenic side effects such as hirsutism. These patients can have hirsutism as well. Okay, so what is not seen? There is decreased FSH. All of the following structures are homologous except. All of the following are homologous except labia majora and scrotum, minora gland, clitoris, and glans penis. Clitoris and glans penis. Which is it? So, ma'am, PCOD, which estrogen? Both estrogens increases, but predominantly even level would be increased rather than normal. Okay. All of the following are homologous except, so here I'm getting mixed response in this. So it's good. Okay, so let's discuss this in detail. Yes. So labia, what is first homologous organs? Homologous organs means they have same embryological origin. They have same embryological origin. So again, you have various structures from these. These structures are arising. They have common embryological origin. So these structures include genital swelling, genital fold, genital tubercle, urogenital sinus. So this genital swelling in females lead to, so this is the swelling which you are seeing here in yellow. Genital swelling in females leads to labia majora and scrotum in male. Okay, so many had commented one, so that is out, right? So labia majora, scrotum are homologous, both are developing from genital swellings. Next is your genital fold, the one which you see in blue here. This is the genital fold. From genital fold arises labia minora as well as the penile urethra and shaft of penis. So you have labia minora, which is leading to penile urethra and shaft of penis in case of males. Penile urethra and shaft of penis in case of males. Next, coming to genital tubercles. So this is what you're seeing, genital tubercles here. Genital tubercles is the development of clitoris and glans penis. So again, clitoris and glans penis. So all the answers which you gave here are already covered, right? Labia minora, penile urethra, glans penis, and clitoris. So even if you don't know the final one, even by ruling out these common things, you can come to the answer. So this question is basically because sometimes such questions can happen where three options might be familiar to you, one might not be there. Try to rule out. Don't be scared by options. Try ruling out many a time. If at least you can rule out two options, okay, so take a like a guess between this and don't skip the options totally. Okay, if you have ruled out two, there is high probability you can be right. Okay, always mark the answers. Okay, so confused? Yes, confused because we have not discussed the final part. Is it, Monica, or is there any other confusion? Yes. So prostate is actually homologous to the Skene's glands, which is your paraurethral gland. So from the urogenital sinus, in females, there is paraurethral glands. Paraurethral glands, which is homologous, which is also known as Skene's glands, which is homologous to prostate in males. And also from the urogenital sinus, what else develops? Also the Bartholin's glands develops. Bartholin's glands, which is also known as greater vestibular gland. And this Bartholin's gland is again homologous to, in males, the Cowper's glands. Okay, so we just mix these two options to understand paraurethral and prostate, Bartholin's and Cowper's glands. Is it clear? Okay, so who was confused, Monica? Is the confusion over? Yes? Yes, take a educated guess. Yes, yes. Yeah, if you are not getting, try to rule out. Okay, rather than making a direct guess in all four options, rather than making a rough guess in all the four options, someone was saying, I'll just guess. तुक्का भी लग सकता है. Okay, so whatever, so try to rule out among these four. Okay, your probability increases if you are just guessing from all four options. Your probability of getting a right answer is just 25%, right? So if you at least rule out two, you have just two options, 50% chance of getting a correct answer. Okay, rule out and come to an option. Okay, many times it so happens that some of the question might not be the things which you directly read. Okay, don't just skip those questions. Many times there are those subconscious memories which are there, which you have seen somewhere, read somewhere. Give it some time, read it calmly, okay, and try to get, like, come to an answer which is common. Okay, don't leave any questions completely. Okay, try to rule out try to pick some key points, even if you get a big paragraph question, which often comes now in FMG. There are long questions, right? Not the direct questions which come. Okay, even if such long questions come for you, just have a look at the final key frame question which is there. Then have a brief look at the question to get the main points. Okay, so that your time is also saved. First, read the last sentence which is there. What are they asking you? What is the core of the question? Then you can go through the question briefly so as to save time. Okay, coming to the next question. You have a 20-year-old patient with history of sharp pain 2 to 3 days every month. That is 2 weeks before her menses. It's 2 weeks before her menses. Okay, so what is the most probable etiology for her pain? Direct question. This is basically a pre-ovulatory pain, that is �𝗏𝗃. Pre-ovulatory pain or 𝗏𝗃. Okay, sharp pain, that is 2 weeks before menstruation. This is basically the pre-ovulatory pain, that is 𝗏𝗃. Okay, yes. So again, there were options on other dysmenorrhea, primary and secondary dysmenorrhea, primary and congestive dysmenorrhea actually. So let's briefly have a look at these types of dysmenorrhea. So dysmenorrhea basically means the pain during your time of menstruation. So again, you have primary dysmenorrhea. Primary is due to all that spasm that we learned, right? Spasm due to PGF2 alpha, prostaglandin F2 alpha. This happens in young females. Usually initial 1 to 2 years, there is no pain because it is anovulatory. Again, connecting with the previous question. Initial 1 to 2 years, there is no pain as it is anovulatory. Pain is just before or along with periods important. And it subsides within 72 hours. Many a time they will give you clinical scenarios like this. So this is your primary dysmenorrhea. In contrast to this, in secondary dysmenorrhea, pain starts few days back or even 1 week back before menstruation, and it persists even after the onset of menstruation. So here prostaglandin is mainly responsible. So your management is NSAIDs. So the treatment of choice is NSAIDs. The other points include pain is intermittent, suprapubic, just above your pubic symphysis. Sometimes it can be associated with some psychological factors. Secondary, as the name suggests, it is secondary to some other pathology, such as endometriosis, such as adenomyosis, usually seen in older females more than 30 years. Sometimes this pain can be localized. Okay, just a brief summary of the dysmenorrhea as well. Okay, for completion. Okay, so moving on. So the screen has been stuck. Yes. So you have a 29-year-old nulliparous female who has complaints of severe menorrhagia, lower abdominal pain since 3 months. On examination, you see that there is a 14-week size uterus with a fundal fibroid. What is the treatment of choice for this patient? Okay, can you give me the answer? So you have a 29-year-old. What are the key things? First, tell me the diagnosis. It is basically fibroid. You are dealing with fibroid uterus. They are asking you what is the treatment of choice. What are the key things that you get from this question? 29-year-old, nulliparous, patient symptomatic, and a large fibroid. What is the management? Will you do hysterectomy? Absolutely no, because she is nulliparous, no, young female. If she was an old female, I would have chosen hysterectomy. Will I wait and watch? No, again, so symptomatic. Will I give GnRH analog? She is nulliparous. She is 29-year-old, again, not GnRH. Can you do myomectomy? Yes. Young females, your answer is going to be young females, not completed family, myomectomy. Older females, symptomatic, completed family, more than 40 years, you can go for hysterectomy. Hysterectomy. Okay, is it? If patient is not symptomatic at all, you can go for wait and watch. Okay, any treatment such as your uterine artery embolization, even endometrial ablation, which is given for AUB, all these things we don't prefer for a patient who is actually desiring fertility, who is nulliparous. Patient desires fertility, nulliparous patient, the treatment is myomectomy for a large symptomatic fibroid. You have a nonavalent vaccine. You have a nonavalent vaccine, which protects against which type of HPV virus. Okay, so as you know, HPV vaccines, again, you have this bivalent vaccine, quadrivalent vaccine, nonavalent vaccine. Bivalent vaccine is your Cervarix, which is against you 16 and 18. It is against 16 and 18, your bivalent vaccine. Next, you have quadrivalent vaccine, which is your Gardasil, which is against 6, 11, 16, 18. Other key points that you should know, 16 and 18 are the high risk strains, 6 and 11 are the low risk strains, which is responsible for anogenital warts. Low risk strains, which is responsible for anogenital warts. They are responsible for the anogenital warts. Yes. Finally, you have the nonavalent vaccine, which is against 9 strains. The strains include 6, 11, 16, 18, 31, 33, 45, 52, 58. I'm so sorry, but you have to know this list because it is important. Okay, this is important. Yes. So apart from this, tell me, how is this vaccine made? This is against L1 capsid antigen. This is against L1 capsid antigen. This vaccine is made against L1 capsid antigen. Okay, so how will you give? The target age group is basically till 14 years. Till 14 years, you are going to give 2 doses as intramuscular injection, and beyond 14 years, you are going to give 3 doses. 3 doses again as intramuscular injections against L1 capsid antigen. Yes. A 16-year-old patient, primary amenorrhea, common question, secondary sexual characters very well developed. You see that there's a bluish bulging membrane. Bluish bulging membrane, you can close your eyes and mark it as imperforate hymen. Imperforate hymen management is put an X-shaped incision. X like this. Okay, cruciate incision and drainage of the blood. What is the other thing which is actually causing obstruction? Everything else will be normal. Blood does not come out. Blood does not come out, accumulate inside. The name is cryptomenorrhea. Cryptocurrency means something which is, you can't see, right? That type of currency. Similar to that, here bleeding is happening, but it is accumulating inside. The other cause could be transverse vaginal septum. How will you differentiate? In transverse vaginal septum, this obstruction is not so low down. It is slightly higher up. So you will see a blind vagina. You're going to see a blind vagina and no bulging bluish membrane in case of this transverse vaginal septum. Imperforate hymen, bulging bluish membrane, and when I do a PR, per rectal examination, there is a bulge through entire length of the vagina. Through the entire length of vagina, you can see the bulge. Okay, next we have 48-year-old patient who is suffering from severe menorrhagia. She has undergone hysterectomy. She wishes to take hormone replacement therapy. So physical examination, breast is normal, X-ray has osteoporosis. What is the treatment of choice in this condition? What is the treatment of choice for this condition? So the problem, yes, please tell me the answer. The answer which I was expecting, yes, Pradeep 2, Bhuvana 2, yes. The answer would have been correct. Yes, it's a very good answer. OCP2, good, good. B, yes. B, osteoporosis, yes. All of you would have been absolutely right if this underwent hysterectomy, if I cut out from the question. Now your answer is B. Okay, all of you are right in this sense. Yes, but the question shows that the patient has undergone hysterectomy. He has underwent hysterectomy. So if the patient has already underwent hysterectomy, so let me tell you the concept. So some has concept, no, we will give one C. Okay, let me clear it to you completely. So the main hormone that I want to give is estrogen, right? So the problem is estrogen is that estrogen will cause endometrial hyperplasia, proliferation of endometrial hyperplasia. So that is why we will give progesterone to protect endometrium, estrogen and progesterone. Suppose patient does not have uterus. There is no uterus. There is no risk of endometrial hyperplasia. I will give only estrogen. I will give only estrogen. So what is the treatment? Estrogen. Is it clear for everyone? So I think some of you told by mistake they have marked and something. So it's very important to read the question thoroughly. So again, let me tell you the algorithm. Main treatment is estrogen. Patient has uterus. There is risk of endometrial hyperplasia. You will give estrogen and progesterone. Patient had underwent hysterectomy. Just give estrogen. Only estrogen. Is it clear? But ma'am, osteoporosis is there. So what? Still for osteoporosis, why does that happen? It's mainly due to estrogen. So I'm going to give estrogen, right? Shivam, can you clarify your question? Did you mean we should give only progesterone? Is that what you meant? Or we should give other treatments of osteoporosis? Was that among these options? Yes, estrogen is protective against osteoporosis as well. Okay, estrogen. So why does all these complications happen? So as you asked, let me just brief up about what happens in menopause. So I understand this is an area which you want to focus on. So briefly about menopause. So menopause, what happens is that basically the follicles have depleted, the level of estrogen in the woman decreases. So what are the things that happens in menopause? Estrogen or estradiol decreases and FSH levels increases. FSH level increases. We see that usually the levels of FSH is more than 40 international unit per liter in a woman who is after menopause. As estrogen decreases, these women have lot of symptoms such as they can have vaginal atrophy. These patients can have vaginal dryness. They can have hot flushes, mood changes, long-term complications such as osteoporosis. Okay, all these things are coronary artery disease. Everything is increased actually. So what will I give for this? I'm going to give estrogen. Main determinant, uterus plus, uterus minus. Uterus plus, estrogen and progesterone, no uterus, I will give estrogen. Final point about osteoporosis, then I'll stop this about this. Not osteoporosis, about menopause, then you stop this topic on menopause. Patient has vaginal atrophy, vaginal dryness. What will you give? You will give estrogen alone. If a patient has vaginal atrophy, you will give estrogen creams. Local application of estrogen or estrogen creams. Okay, when you are giving creams, you need not give progesterone. You can just give topical estrogen. Is it clear? All concepts on menopause clear? Yes? We'll make this right. Okay, moving on to the next question. Okay. Yes, you have a 64-year-old female who has presented to you with complaints of mass descending per vagina. Topical estrogen in the form of vaginal rings, creams. Topical estrogen in the form of vaginal creams here, not rings, in the form of cream actually. Ring again, it is going to be systemically absorbed, right? It is in the form of estrogen creams. Yes. So, yes, very good. So, S20 65-year-old. So, again, this is the last question. Like, so you can just read the last line. What caused this ulcer? That is it. What are they asking you? They are basically asking you about prolapse with ulcer. So, if I read the complete question, mass descending per vagina, aggravated by straining, means prolapse. Grade 3 uterovaginal prolapse, decubitus ulcer. What caused this ulcer? Right? So in between, I saw an answer as 3, which is a commonly marked wrong answer. So this ulcer is not due to the trauma or friction that happens. This is basically due to venous congestion. This ulcer is due to venous congestion. As this uterus is prolapsed outside, again, the venous return, the lymphatic return decreases. This is due to venous congestion. So how will you manage this? You will reposition the uterus. You are going to reposition the uterus. Management is by repositioning along with packing. You are going to do packing and repositioning of the uterus. So suppose if there is a question, patient has prolapse, same question, no ulcer. What is the main management if they ask you? The main management is remove the uterus through vagina. Grade 3 prolapse, no ulcer or anything. The definitive management is vaginal hysterectomy and pelvic floor repair. If they have an ulcer, treat the ulcer. Okay, main management, definitive management is vaginal hysterectomy and pelvic floor repair. Okay, the main management. Yes, as she is old, exactly, 64-year-old old patient, completed family, or without anything. They just give you 3rd-degree prolapse, no age or anything. You assume it's an old patient. The definitive management is vaginal hysterectomy, pelvic floor repair. If they specifically tell you it is a young patient desiring fertility, what will you choose then? It is sling surgery. Young patient, sling surgery. Old patient, vaginal hysterectomy. Old patient, unfit for surgery. What is it? Now you can just put a ring inside, which is known as pessary. Yeah, old patient who is unfit, think about pessary, and someone has commented 𝗲𝗏𝗏. Yes, 𝗲𝗏𝗏 is another surgery, which is actually 𝗲𝗏𝗏𝗏𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 patients. After choosing pessary, the next option that you can choose is 𝗵𝗺_colpoplisis. Patient not willing for pessary, already pessary has been tried and failed, or in those situations, you can go for 𝗵𝗺_colpoplisis. Yes, coming to the next question. Yeah, again, I'm going to the last slide. You have what is the diagnosis, ultrasound images given. Okay. So in such questions, just briefly go through the option fibroid, PID, some ovarian tumor, endometriosis. With this option, let's go through it. Menorrhagia, dysmenorrhea, 18 to 7 centimeter, homogeneous mass, ground glass appearance. Okay, this is basically a ground glass appearance, which is typical of your endometriosis. This is also known as your chocolate cyst. Chocolate cyst, endometriotic cyst, also known as endometrioma. What is the management of this? If you have an endometriotic cyst, which is more than 4 centimeter, that is equal to or more than 5 centimeter. Beyond 4, whenever you go, your management is going to be cystectomy. You are going to remove the cyst. Beyond 4, that is 5 or above, you are going to remove the cyst. That is, cystectomy is the management of this condition. So ground glass appearance, which is the cancer that can develop from this endometrioma. The cancer associated is clear cell cancer. Very rare, but if they ask you which is the most common cancer, which is the cancer, it is clear cell cancer, followed by your endometrioid type of ovarian cancer. So what are the points we discussed? If a patient has all this pain, is given the question, if we have ground glass appearance, the answer is endometrioma, more than 4 centimeter, management is cystectomy. The cancer associated is clear cell cancer, followed by endometrioid type of ovarian cancer. So endometriosis, always question will have a lot of pain. So endometriosis, most common symptom is pain. Pain could be various types. Most common type of pain is dysmenorrhea. They can have dyspareunia, they can have chronic pelvic pain, they can have triple dysmenorrhea, that is pain before menstruation, during menstruation, after menstruation. Always there is pain. Question gives you pain, different types of pain. Think about endometriosis. Apart from pain, the other symptoms include the patient can have infertility and ethnic cell mass. Infertility and ethnic cell mass are the other symptoms that are associated with endometrioma. Pain, infertility, and ethnic cell mass. Okay. So as we are in endometriosis, can we discuss few more points which always come? If they ask you what is the initial investigation that you're going to do, okay, every time there is a question on endometriosis, I can't skip this topic without us discussing those. Now, if they give you the same question, what is the initial investigation that you do? Initial investigation is TVS. What is the investigation of choice in endometriosis? If they ask you what is it? It is laparoscopy. Laparoscopy. If they ask you what is the confirmatory or the gold standard investigation, which was asked last time, gold standard or confirmatory. The gold standard or confirmatory investigation is, ideal answer should be laparoscopy and histopathology. So again, in the options also, I can see students writing lapro, histopathology. What will you choose best? Like you don't like, I always say that examiners are not so big of heart. They won't always give you lapro and histopathology where the answer becomes so easy. They will give one lapro, one would be histopathology. Now, which will you choose? The best answer is HPE. HPE, if that is not given in the option, next you will choose laparoscopy, right? HPE followed by laparoscopy. Very good, Bhuvana. That's correct. HPE followed by laparoscopy. Pradeep, you are right. It's HPE. Maulika, correct. Phobia, Ashish, excellent. Shubham, excellent. Yes. Previous ask question as well. Very important. Okay. Always there is question on this endometriosis. What is the gold standard for diagnosing adenomyosis? What is the gold standard for diagnosing adenomyosis? Yes, good. I'm getting option A, 2, option A, MRI. Okay. So the gold standard for adenomyosis, it's not MRI. Okay. So MRI main problem is that what happens in adenomyosis? Basically, in adenomyosis, so I'm just adding one more option. Okay. Now you tell me the answer. Now, final option is endometrial biopsy. Okay. So I did not add this option here. Now can you tell the answer? Yes. 𝗬𝗵 5. Good. Yes. Biopsy. Yes. What biopsy? Tell me the options, na, Pradeep. Endometrial biopsy. Yes, Pradeep. Okay. Okay. So why did I add the answer 5? Did I forget to add this option, which is the correct answer? Because Pradeep 5, no biopsy. Aparna, HP, what HP endometrial biopsy? Yes. Yeah, Ashish is going with 5. Yes, that's the answer which I wanted from you. Okay. Many times I see students marking this 5, maybe because somewhere they have learned just biopsy. Okay. So let's start from the basics. Okay. What happens in adenomyosis? Okay. Students, be with me. So adenomyosis, what happens is that this endometrial glands and lining, endometrial gland and stroma is present in the myometrium. So this endometrial gland and stroma is in the myometrium. So where is the pathology? This is present in the myometrium. So suppose for this patient, I go in and take a biopsy from the endometrium. What will endometrium tell me? Nothing. Where is the pathology? In the myometrium. Is the endometrium affected? Absolutely no. So will endometrial biopsy help me? Absolutely no. Many times students ask me this question, endometrial biopsy. It's not endometrial biopsy. So from where should I get this biopsy? It is from this myometrium, from the muscle part. Can I take a biopsy from the muscle? No. What can I do? Once I remove the uterus, I will, after hysterectomy, we usually send for histopathology. So the definitive management is hysterectomy. Take out the whole uterus. It is hysterectomy. Definitive management is hysterectomy, and the definitive diagnosis is histopathology. Which histopathology? From the uterine muscles itself. Okay, endometrium is normal. It is not endometrial biopsy. Why not MRI? Many a times the MRI does not very clearly show these changes. MRI is often inconclusive. MRI is taken as the investigation of choice, but not gold standard. Gold standard means that investigation after which I'm 100% sure. There is no doubt. There is no scope of doubt after doing that. Okay. So what is the gold standard in case of adenomyosis? It is histopathology. Very important. What is the definitive management in case of your adenomyosis? It is hysterectomy. Adding on few more points about adenomyosis. Adenomyosis, usually it is seen beyond 40 years, that it is seen in 40 to 50 years. Most of the conditions like your endometriosis, fibroid, all these are seen in nulliparous female. But you see that adenomyosis is seen in multiparous female. Adenomyosis is seen in multiparous female. So what is the pathology? Endometrial gland and stroma is present in the myometrium. Endometrial glands and stroma is present in the myometrium. And again, in this, the complaints that the patient have include the patient can have heavy menstrual bleeding followed by pain. The HMB is the most common symptom followed by pain. Again, these patients are multiparous above 40 years. That is why we can resort to a hysterectomy to completely clear out the pathology in this. Is it clear, guys? Clear? So what will you choose now? It's not MRI, it's histopathology. It's histopathology. Okay. So you guys, well, everyone was so attentive and writing the comments, and it is really good. Right. So all the very best for your exams. Okay. I think your preparation is right on track. Let the stress not affect you at this point of time. I'm sure. I'm perfectly sure that you're going to do excellently well in the exam. Okay. That effort is the thing that matters most. Okay. Moulika, Shubham Gill, Ashish, Okay, all the very best for your exam. Okay, I know it has been a 2-hour session, though it was planned for 1 hour, because I wanted to add in more points. Just discussing question, answer, I don't think that will be much useful. Okay, so yes, hope to hear from you again after the exam as well. And you can connect to me at any time. My Insta account is OBG with Gayathri. OBG with Gayathri. If you have any questions, doubts, you can connect to me on Insta as well. नीट तो कैंसिल हो गया, प्रभ का क्या करूं मैम? शुभम वही पहले बोल रही थी ना, जो भी है नीट पीजी कैंसिल नहीं, जो भी आप प्रिपरेशन कंटिन्यू रखो. ओके शुभम, आर यू प्रिपेयरिंग फॉर नीट पीजी? इज इट शुभम? So if you are FMG student, don't think about NEET PG cancellation. Absolutely no. Stay focused on your exam. Keep on studying. Okay. If you are someone who are just experienced this NEET PG cancellation, my suggestion would be please don't lose the pace as of now. This is very important. I know this has been very disheartening. Even for us faculties, it's so frustrating that this got cancelled just 12 hours before the exam. So at this point of time, the ideal thing would be once the next they have introduced when the next PPG is going to happen, you can plan one more round of revision, which is going to actually help you a lot. But in this meantime, till you have this uncertainty, doubt, where you want to channelize your mind, do grand test. Okay, keep on doing questions, do grand test. And if at all there are some areas, of course, obviously on the last day of exam, we always feel like, okay, हमें ये पढ़ना चाहिए था, वो तो भूल गया, एक और दिन मिल जाते तो हम ये कर लेते, वो कर लेते. Okay, this is your that time. If at all that some topic is there, you try to cover it. Okay, definitely you try to cover those areas. And if nothing at all, you don't feel like reading anything, just give tests, give some grand tests, so that you have to keep it rolling. You have to keep the momentum, because at this point of time, there are so many students who are behind you as well, who has come into the race. They are preparing. You should not lose your momentum at this point of time. Okay, keep on reading. Let it be something grand test, whatever, does not matter. Please don't lose the momentum in the big picture. I know this is very sad, disheartening. We feel like if this had happened, if NEET had happened, if NEET was not postponed, all these things would be there in your mind. But still, let it not affect you. Once the big picture, once you get the specialty of your choice, once you are there, this will actually, sometimes you should feel that this was a good thing that NEET was cancelled. I could do so much more and my rank improved so much. Okay, that should be your final motto. Okay, so maximum, utilize this time to your maximum. At least give grand test. If you feel too exhausted, you can take a break of 1 day or 2 to refresh yourself, but don't be in that full of sadness or that dejection state for a long time. Keep on moving. Okay, that momentum has to be maintained. We don't expect it to happen in very recent days. Minimum of 2 to 3 weeks will pass before the next exam. Again, once we only have this confirmed thing, only we can tell about this, Shubham. We can't say for sure, but maybe 2 to 3 weeks would be definitely, and even 1 year. Yes, anger is at peak for everyone, Shubham. Yes, but the anger will not help us, right? There are things which we can control, only those things, right? So there is no point. Everyone felt like, I can understand so many students travel for such a long distance, so much waste of resources, energy, time, everything is there. But yes, that denial or grief phase should pass and you should come back. Okay, you should come back definitely. Okay, don't waste a lot of time. Okay, you are a very good student. Keep on going. Not only you, everyone who has attended, I'm sure all of you are going to do very well. Keep on learning. Okay, keep on learning. Let it move on. Once everything is cleared, you'll be relaxed. You can sit back, around, say like this. Okay. Ma'am, explain hydrops fetalis, Ashish. Good question. What is hydrops? Hydrops basically means there is collection of fluid in 2 or more compartments. So when I'm doing an ultrasound, I see that there is accumulation of fluid in more than or equal to 2 compartments, or I can rephrase it as more than 1 compartment, right? Don't make this mistake. More than 1 means equal to 2 or more than 2. So it is there in more than or equal to 2. That is more than 1 compartment. So don't learn both. Just learn 1, more than or equal to 2 compartments. So this hydrops, this accumulation of fluid, which all compartments could be there? It could be pleural effusion, accumulation in the lungs. It could be in the heart, just a diagrammatic picture. It could be pericardial effusion, pericardial effusion, accumulation of fluid in the heart, pleural effusion. There could be accumulation of fluid in the abdomen, that is ascites, or there could be accumulation of fluid in the skin, that is edema. Usually it is seen in the scalp, which is known as scalp edema. Scalp edema. So it could be due to scalp edema, pleural effusion, pericardial effusion, or ascites. This is how you diagnose this in the ultrasound. So again, it could be due to immune causes, non-immune causes. If they ask you what is the most common cause, the most common cause is actually NIH, non-immune hydrops, which is most commonly due to the cardiac causes. The other causes include any thoracic problems, infections such as parvovirus. Your immune hydrops, so most common is non-immune hydrops more than immune hydrops. In immune hydrops comes your RH immunization. Very good, Shubham, NIH, yes. So in immunization, immune hydrops comes your RH immunization. Yes, okay. So this is about hydrops. Again, hydrops has very poor prognosis. Okay. So again, when I take the RH spectrum, hydrops is the final stage, the severe form of RH isoimmunization. Okay. So all the very best, students. Take care. Okay. And you can connect to me anytime on Insta as well. Okay. All the best for your exams. Hope there is no further questions in the chat box as well. Okay. So see you on the other side soon. Do your exams very well. Have a very calm, peaceful mind. Go for your exams. Study well. Utilize this time to the maximum. Okay. Okay. All the best for your exams. Okay. Thank you, Ma.